Welcome all of you, wherever you are in the world today. Thanks for participating in the fourth day of the WFNR series of webinars celebrating the Brain Awareness Week. Brain Awareness Week certainly is an important issue to alert the world public on what the brain is, brain research, work on the brain, and especially also brain repair. And WFNR feels to be responsible in some sense for dealing with the issue of brain repair. The brain is a very important organ, it's probably the best we have. Nevertheless, it's a soft organ and it's a very vulnerable organ, and it's up to a lot of insults and injuries, maybe by accidents, as traumatic brain injury, maybe by vascular disorders as stroke, maybe by demyelinating or inflammatory disorders as multiple sclerosis, or degenerative disorders as dementia or Parkinson's disease. So brain repair certainly is an extremely important issue. I'm very glad that we have two excellent experts with us today talking about strategies of neurological rehabilitation with a special emphasis in low middle income countries. This is certainly a very dramatic problem we have, and the WFNR tries to be a sort of a forerunner to improve the availability and the quality of rehabilitation services in those many countries in the world where hundreds of millions of people at the moment do not yet have a chance to have decent access to neurological rehabilitation. So our first speaker will be Professor Mayowa Olabi from Nigeria, a friend for many years, and he is the regional vice president for Sub-Saharan Africa for the WFNR. Has a vast experience. He's extremely active as a researcher, and he's also extremely active as a person dealing with, let's say, service problems and public health problems in the area. Mayowa, the floor is yours. So we have a...
Thank you very much. Yeah, pre-recorded. Christian?
Yeah, we can start.
Good day, everyone. And great thanks to the organizers of the activities to commemorate the Brain Awareness Week under the auspices of the World Federation for Neurorehabilitation. For this great opportunity to talk about neurorehabilitation in low and middle income countries. We know about the Rehabilitation 2030, a call to action which intends to meet the needs of those who require rehabilitation, particularly neurorehabilitation across the globe by 2030, including in low and middle income countries. Of course, we are very familiar with this slide, which shows the distribution of public spending on health, which is very lean in the southern hemisphere. We know that low and middle income countries bear most of the burden of neurological conditions, more than 80% of the burden of neurological conditions. But as we've seen, they have only a very small part of the global financial and healthcare resources to combat it. I mean, if we look at the Neurology Atlas by the WHO, we will see the deficiencies in terms of manpower, particularly in low and middle income countries. And the other problem or challenge is that available knowledge of evidence-based recommendations are not translated to reduce the burden of stroke and other neurological conditions in low and middle income countries. So to treat this problem, we coined the TREAT acronym, which means therapies, meaning we need to ensure there is availability of therapists for multidisciplinary care, including teleservices and task sharing, increasing the number of settings for care across LMICs. And research is very important into low cost effective pragmatic solutions, prevention of complications, locally produced assistive devices, and guidelines for rehabilitation that can be implemented across the globe. Enlightenment is very important because in low and middle income countries, there is even not only a supply problem, but also a demand problem because people are not even aware about neurorehabilitation or the services or the potentials or the impact of neurorehabilitation services and the cost effectiveness. So it's important to enlighten people through community engagement activities to inform, to inspire, to involve them and educate the patients, caregiver, and family, which is extremely important in rehabilitation of neurological conditions. Then advocacy is important to mobilize resources that would help with providing manpower and providing other resources that including devices, equipment that is required to improve neurorehabilitation in low and middle income countries. Working through NGOs, ministries of health, and the societies and organizations at regional level, national level, and international level. Then training is particularly important, training, retraining through webinars, workshops, conferences, but more importantly, career paths, that are going to help both undergraduates as well as postgraduates, career paths that will help to build the necessary for research and for all the things. To get it started in sub-Saharan Africa, we started a new project in Ibadan, which is actually a city, a pace-setting state, so to speak, in Nigeria, which has its first skyscraper, first TV station, first university, and so on and so forth. And of course, the new rehabilitation established, which is meant to be the regional hub and has been the WFNR Secretariat since its inception for this region of the world, and is expected to help both in terms of providing services, being a model center for rehabilitation, and also spearheading. So it was established in 2010, and the staff strength is increased, and utilizing both the humanistic as well as holistic model of neurorehabilitation to provide. Of course, we all know the spiral, the recovery spiral. We start with assessment and evaluation, planning and goal setting, and therapeutic intervention, and a vast array of rehabilitation services or therapeutic services that may be required. Patient as king, goal setting, of course, physician coordinates activities, working with therapists and caregivers, and providing an array of services that may be required: speech and language therapy, physiotherapy, cognitive rehabilitation, occupational therapy, psychotherapy, and so on and so forth, including even music therapy and holistic therapies. And of course, coming up with artifacts, for speech therapy, and fabricating things that might be useful at low costs that can help not only with speech therapy but also with other aspects of so rehabilitation is offered at different settings. We're just using stroke as to illustrate that acute care, subacute, outpatient, and we also supervise and coordinate home-based, community-based, and of course long-term sustained rehabilitation. Just showing the same thing using another format. So community-based, home-based, family support things that we also do to supplement outpatient care after patients have been discharged and to reduce the need for frequent visits. So hyperacute rehabilitation within 72 hours, that's using stroke as an example. Acute stroke after 72 hours, and then post-acute after discharge from acute care, and then of course outpatient care when patient has been discharged home and is coming on outpatient basis, and then of course home-based and community-based rehabilitation. This is actually an ecosystem, and there should be cross-referral across all these paradigms, and this also applies to many neurological conditions and traumatic brain injury, and so forth. So once a patient is deemed fit to be discharged, it may not be feasible for them to come for daily physiotherapy. So we try to supplement by whenever possible, teaching the caregivers or care providers at home to do some of the rehabilitation activity, therapeutic activities that are not too intense, but they can do at home in order to increase the exposure, the duration of exposure and practice to such rehabilitation interventions like physiotherapy, like speech and language therapy, or even cognitive therapy. Of course, this is done initially in conjunction with the experts, with the therapists, and then when the patient goes home, that can be practiced, and then they come back and things are checked. They can also be telemonitored, and then they are moved to the next level uh, for the various therapeutic interventions. So home-based intervention or rehabilitation involves task shifting as well as task sharing. And like I mentioned, it also involves professional therapists in terms of supervision. And sometimes the therapist also visits the home to ensure that the home environment is made suitable for the patient's mobility and other activities of daily living. So goals for home-based rehabilitation will include transfer training, mobility training, uh, timed independent or semi-independent feeding routines, activities of daily living essentially, and then ensuring that patient is able to take his or her medication, either self or supervised, and secondary prevention for conditions such as stroke are also implemented. Continence training, all of these are very important, just to ensure that patient is able to carry out the basic activities of daily living, and in some instances, instrumental activities of. So, and of course, it's also important to ensure that infections are avoided or detected as soon as they develop and treated. Pressure sores are avoided by using waterbed, for instance, or hair mattress. Aspiration and chest infections are prevented by not feeding when it's not when there is dysphagia, or including even silent dysphagia, and when aspiration may occur. And if there is infection, chest infection, this is detected on time and also treated to prevent any complications. Sexuality advice, clinical stability, all of these are very important. And of course, this is also combined in many cases because many of these patients have comorbid conditions and they still need to visit the hospital. This is combined with outpatient care and it's not solely home-based rehabilitation program for other things. Then there is a community-based rehabilitation, in which case this is implemented through the combined efforts of people with disabilities, their families, communities. It also helps with community reintegration, education, vocational, social, and other services. And something that can help improve access to rehabilitation services, particularly after discharge for patients, and that can ensure that they continue to recover even afterwards. So support for training, restarting driving. This is actually about community reintegration, use of public transport, return to employment, return to driving, attending to extended personal affairs, um, uh, social activities. All of these are very important for reintegration, both to ensure that the patient is able to participate in terms of domiciliary roles as well as other societal roles, including occupational roles. So, and we've conducted research in all these areas. For instance, we conducted research on stroke rehabilitation in domicile, in place of domicile at home, patient's home, as well as primary health care center. These works, and the outcome measures were motor function, balance, handicap, and all of that. We found that physiotherapy intervention at the primary health care center and respective of stroke survivors similarly improved their clinical. And of course, the ultimate goal of rehabilitation is to improve quality of life. And so we developed this health-related quality of life instrument, the HR code 40, which is novel, shortened, multiculturally valid, and actually the first holistic measure for stroke. And this has been validated in more than 10 different countries, translated into more than 5 different languages across the globe with publications. These are just a few of the publications. And in addition, we also know that it is sensitive to change and responsive to change. And this has also been published. And we've used this to examine the relationship between stroke severity as well as the different domains of quality of life. And we find that physical, psychological, and cognitive domains are more impacted compared to the soul spirit domain or sphere, which is resilient. And going further, we also came up with the concept of the stroke recovery cycle, whereby improvement of life purpose score, that is sense of purpose in life, improves meaning in life. It helps to restore meaning in life and promote a sense of meaningfulness in life. And of course, this helps with internal adaptation, coping skills, emotional well-being, and motivation, which in turn helps to improve quality of life by improving practice and the impact of the various therapeutic interventions such as physiotherapy, speech and language therapy, and cognitive therapy. Because where there is motivation, when the patient is well motivated, is able to practice intensely and for sufficient duration, and that also has a positive feedback by reinforcing the sense of purpose in life, meaning in life, and improving the quality of life overall. These are based on the determinants of quality of life across different settings, cultural settings, the stroke recovery. So advocacy is very important. We've discussed T and R, which is therapy, research, then advocacy. Very important to create awareness, and we've been doing this. And we have right now WhatsApp group that is actually almost up to 1,000. You know, initially when we started, we were using emails, and we have over 500 people. But right now, we actually have WhatsApp group that is over 1,000 people, you know, across the continent of Africa. And we are also ensuring that more countries are getting involved, and more networks are being propagated. And in 2028, we will have the opportunity, Africa will have the opportunity of hosting the World Congress for Neurorehabilitation. So then we're also establishing sister organizations to further foster access to neurorehabilitation. The African Stroke Organization was established in October 2022, and since then we've had African Stroke Organization conferences on a yearly basis. We had in 2021, we had in 2022, and we're going to have this year, 2023, November 2nd and 3rd, and it's going to be hybrid format for the very. Now came on the scene the Intersectoral Global Action Plan against Epilepsy and Neurological Disorders, to which more than 197 countries subscribed. We're leading the domestication of this in 47 countries in the African region. We are focusing on epilepsy, stroke, dementia, headache, and Parkinson's disease in the first instance. We're almost done with the situational analysis, and we are going to do a launching of this that would involve ministries of health across the 47 countries. This is being planned, and we're working very hard on this. Of course, rehabilitation is one of the key pillars of the quadrangle, of the neurology quadrangle, as part of the neurology revolution, and this is going to ensure that rehabilitation services are improved and are accessible across in Africa. So training is also very important. So we've done this through different networks, this Siren network. We have to realize that there is a very huge gap in terms of training in neurology across the continent. You can see that many countries do not even have any, training programs. We have some training programs in West African region, and maybe a few that are just springing up in East Africa more recently. So there are different career tracks, neurology, neurosurgery, for psychotherapists. You can see physiotherapy, occupational therapy at undergraduate as well as postgraduate, and of course speech and language therapy, orthotics, prosthetics, and quite a number of other and fields which are not included there. And we've conducted several training events, and we intend to integrate some of these training events into our upcoming conferences, as we have done severally. These are just some of the pictures from previous training activities which we've embarked on all the way from 2017 till date. Sometimes we do webinars, some of these are actually physical. This is actually the launch event of the Nigerian Federation for Neurorehabilitation, in which Professor Michael Barnes was physically present in. These are other training programs that we've had, as you can see. And yeah, this one also, we had several people who are present here, including Wayne Feng, including Barbara Wilson, including Caterina Pistarini, and so on and so forth. And then across the continent, not just in Nigeria, we've been conducting trainings. This was during the COVID period, that we did some of these training activities in Egypt. And some activities are also going on in the Francophone African countries, and some are planned even for next year as well. And in fact, there are also some activities going on in SANRA, that is Southern African Neurological Rehabilitation Association. But altogether, as a continent, we are holding the World Congress for Neurorehabilitation in 2028, but we are already forming synergies across the continent to ensure that neurorehabilitation activities are promoted. So we're expanding, as I mentioned, and they were conducting more and more activities. And then we had a stroke leaders summit just last year, and of course we also had the NFNR activity this year, October 31, November 1st, 2023, the NFNR WFNR Africa program we hold just before the African Stroke Organization conference, the third in the series that we're holding in 2023. Then we have a career program, the Talents program, which is supported by the National Institute of Health of the United States of America. 5 mentees, a mentorship program, 5 mentees per year across neurology fields for 5 years. So we're in the second year, and we have the second cohort is going to be selected and interviewed very short. So, well, all of this in the context of the neurology revolution, and hopefully we are able to bring to bear the promises of the Human Affectome Project, Human Connectome Project, the Human Genome Project, genetic engineering, gene therapy, brain computer interfaces, neurotransformics, neurorobotics, combined with neurophilosophy, medical sociology, literary arts, spiritual psychology, neuropsychology, neurolinguistics, and neuroethics, to ensure that using a One Health concept, we'll be able to promote brain health and neurorehabilitation services, improving quality of life of people that suffer neurological conditions across the globe. We will work through interdisciplinary activities, multisectoral, involving multiple stakeholders, with co-design and co-implementation ecosystems across the globe. So to summarize, therapies are very important. So we need to increase the number of therapists on the continent, and of course in other low and middle income countries. Research is very important to come up with low cost, effective, pragmatic solutions, prevention of complications, enlightenment, community engagement activities, advocacy, and of course, training. Thank you so very much for this wonderful opportunity. And I'm sure you will continue to have an exciting time as we celebrate the best of mankind, which is actually the brain. Thank you so very much.
Okay, Mayowa, thank you very much for this nice survey on the situation in Africa and all the efforts you're doing jointly with a lot of organizations worldwide. I may ask the audience to actively participate by using the question answer button and to ask questions, take the opportunity. I may also welcome Stephanie Clark, in the meantime, the former president of the World Federation of Neurorehabilitation, extremely experienced person, especially in the field of neuropsychology, neglect, and patients, and also Apurva Puranik from India, who has also joined us in the meantime, as far as I can see, as possible additional discussants from the panel. So let me have a short look at the question and answer section. There is obviously one question from Cynthia Renzi. One of the ways we can expand physical medicine and rehabilitation medicine and hence neurorehabilitation in Africa would be to introduce this specialty as a postgraduate training. Is there any plans for this to be developed in Africa? I think Mayowa already alluded to that, but you can answer that better than I.
Yeah, thank you very much. Certainly, there are programs for neurophysiotherapy, in University of Ibadan and in other places in Nigeria. And we know that the activities in terms of these in the East Africa is still lagging. Perhaps apart from South Africa, in Southern Africa, is still lagging. But in Nigeria and some other West African countries like Ghana, postgraduate programs, PhDs in neurophysiotherapy is actually possible and feasible. And so we can support if you are interested, or you know people who are interested in having postgraduate programs, masters, PhDs in neurophysiotherapy, we can support that. Thank you very much.
Okay, the other question is similar about the introduction of a specialty of physical medicine rehabilitation in Africa. You also partly at least answered that. As far as I can see, there are a lot of activities going on to improve the academic education. But this is only one aspect. I think it's probably even more important to increase the awareness and education in general. We will see. Someone asked about who's in charge of the Egyptian WFNR coordination. I think it's Professor General Awad at the moment, as far as I know, but we will give you the information.
Yeah, so I think the program that we organized in Egypt was actually with Fuad Abdallah. So, but if they reach out to me, I can reach out to whoever is in charge through Fuad Abdallah.
Okay.
So I can handle that.
Okay.
If an email is sent to me, then I can coordinate and link with the Egyptian group.
The Egyptian group. And Luria Akari is asking if there are any concrete opportunity to collaborate with these associations. Certainly, and I think Mayowa is also happy to give you the links and for cooperation, I think. Okay, let me see any more questions at the moment. So let's open it to the panel. Stephanie, any questions or comments?
Thank you very much for this very clear talk, Mayowa. It was really great. Could you perhaps outline the possibilities to join online some of the educational occasions from WFNR? Because this may be possible even if you cannot travel immediately.
Yeah, so the activities that we conducted in the last 2 years, in 2021, November 2021 and November 2023, actually, more or less, we fixed November 2nd, November 3rd of every year for the African Stroke Organization Conference. And usually we do the World Federation for Neurorehabilitation, NFNR, African Region Conference alongside. But last year we felt that members of the NFNR and WFNR felt that it should actually be distinct, even though they may be one after the other, to allow people who are going to travel physically to be able to attend both together consecutively without needing to spend extra cost in terms of making trips. So it's actually been hybrid. It's been hybrid, and we usually share the link. So maybe we will publicize these more, disseminate these more through Tracy Moore, through the WFNR Secretariat, to allow the global community to participate more. So we're going to do that. And the one that we did in Benin, the Francophone countries, also last year, like I mentioned, that was also hybrid. Those who are physically in Benin, joined, and then others joined online. I joined online. Professor David Good also joined online.
Thank you.
Okay. Apurva, can you hear me? Well, I don't know. Well, Mayowa, you alluded to a very important aspect, which is sometimes forgotten or neglected, especially in Western countries, I must say, and that is the spiritual aspect of rehabilitation. The brain, of course, is not just a cognitive organ, it's also, in some sense, if you like, depending on your metaphysical positions, the brain certainly is also a spiritual organ. Would you like to comment on this further? Because I think definitely it's as much a neglected field as motivation as in neurorehabilitation.
Yeah, absolutely. It's an extremely important, even from patients' perspectives, because we did studies to find out from the patient's perspective what they feel about the different domains of quality of life, physical, psychological, psycho-emotional, cognitive, and spiritual. And many of them actually said, the vast majority said the spiritual aspect is extremely important. I know that there are challenges in terms of spirituality, in terms of defining it, but there has been a lot of work, actually an exponential rise in terms of people trying to explore the interface, the intersection, the nexus between health, brain health, and spirituality, and that is growing. Of course, while this is growing, it's important also to allow for convergence of knowledge, with other fields, working with medical humanities, working with neurophilosophy and neuroethics, so that we can be able to define these concepts more clearly, and at the end of the day, be able to utilize this. Even though it's abstract, but it's extremely important, because there is a concept of Ikigai, which has been linked, is a related concept, which has been linked with longevity in the Japanese, whereby individuals are able to place themselves, are able to understand and find their place and purpose in the universe. And this is also represented in Maslow's pyramid, whereby self-transcendence is really the peak that everyone should aim for. So at the end of the day, it's very important to achieve both internal balance and external coherence. And meaningfulness is extremely important in driving rehabilitation, because, I mean, what's the use of, if I'm able to use my limb, for what purpose, how does that translate into me really having a better life? I know that in neurorehabilitation, we usually focus at, or medicine generally, we focus at, let's prolong life, let's add years to life. But sometimes there is always this philosophical question, and the place to even ask this is when people are experiencing neurological deficits, or they're not able to do things. And then people start wondering, if someone is like functioning like a vegetable, so to speak, in a vegetative state, of what use is that life, of that prolonging that life? So it's important not only to prolong life, but actually to add life to years. But beyond that, it's also important to add meaning. I know that many times we talk about community reintegration, role, participation, and all of that, but beyond that, you want people to be able to self-realize, understand their role in the universe, either cosmically or metaphysically or physically or whichever way, and find balance, which the Japanese call Ikigai, and which has been shown actually scientifically to have measurable, significant impact in terms of longevity and in terms of quality of life. So it's an extremely important aspect, which we should not neglect, in as much as we're also focusing on Human Brain Project, Human Connectome, Human Affectome, Neurogenomics, Transomics, and all of those. We should not neglect a very, very critical element of life, purpose of life, longevity, mortality, immortality, which has reverberated human existence across generations from the time of Plato up till now. So, and it's very fundamental that we use whatever we know through this new revolution about neurology revolution and brain health to harness these resources, and bring it to bear in terms of helping people to live better life, impactful life that is transformative, useful to us, and even to the universe. We all know now how important planetary health is, Thank you so very much.
Well, thanks very much, Mayowa, for this comment. I think we, in the WFNR, we now have a new special interest group in neurophilosophy, and I hope that we will work a little bit more on the transcultural aspects of thinking about goal setting, about values, and about the sense or nonsense of human life in this respect, because that is, of course, critically important when it comes to define what the hell we do rehabilitation for in patients. And I expect a lot of input from this aspect, especially, the Western thinking is a positivistic thinking in the sense that we try to do science, have Cochranian ideas, how to generate knowledge from data and to make decisions from knowledge and all of this, but sometimes we forget other extreme, the important aspects as well. We hope that we get forward a little bit in this respect, and therefore, Mayowa, I'm especially grateful for your impact in this respect. Any other comments from the panel? Horvath, can you hear me?
Yeah, absolutely. Just to quickly add, to summarize what you just said, it's not everything that counts that can be counted, and it's not everything that can be counted that counts. I know we always want to measure, but it depends also on our instrument. I mean, to illustrate with the electromagnetic spectrum, for instance, if you don't have the special instrument, the higher realms of energy, you can't really measure them, beyond the visible spectrum, then there is the gamma spectrum and perhaps even some other. And as you go to the higher energy realms, so to speak, the wavelength shortens and the speed increases, and you may not have the appropriate instrument to capture. So really not everything that is important that can be measured, for instance. I mean, the intensity of enthusiasm, for instance, I don't know whether we have a scale for that. The intensity of enthusiasm to spread WFNR activities across the globe in Pope Professor Volker Wombat, for instance, we really don't have something to measure that. Yeah, but it's very important.
But in actual fact, I think it's very important that you cannot do neurorehabilitation without having an ontological framework behind that. And there are multiple ways of dealing with that. And I think, especially as me, people in the Western world who have been apprenticed to some particular sort of philosophy, on the other hand, can learn an awful lot from people from other areas of the world who may have a different style of thinking, which is as useful as the Western one is, probably. And I hope that within WFNR, we will have a chance to bring this forward for a very nice intercultural interaction, especially also on these aspects. And I think that will also be helpful to clear many of the hostilities in the world if we come across with some clear answers to that. Okay, any more questions? Nirmal, question to Mayowa?
Up to my talk.
Okay. Okay, if there are no other, let me see, anything from the question of? No. Not at the moment, so we go on to our next speaker, which is Professor Namal Surya. Probably needs no introduction here. Namal is president of the Indian Federation of Neurorehabilitation. He is also the regional vice president for this area. And he was the organizer of one of our world congresses in India, which really, I think, looking backward in some sense, very prompted up the idea of neurorehabilitation in this part of the world. And we are very grateful to you, Namal, in bringing this forward. And so we can go on with your talk. You do screen sharing, as far as I know. See if it works. Yeah. Christian, Namal, anything as introduction?
I think that's enough, and a few more this slide can tell that how it is. It's always challenging to, do the neuro rehabilitation in developing country, and I'm going to give a little bit more about bridging the gap. How do we enhance the services in developing nation? And I'm extremely thankful to you for taking this forward in this Brain Week, which is very, very, very important for. So I will be in 3 phases: introduction, challenging in providing neuro rehabilitation services, and strategy to improve neuro rehabilitation in this country. All of you know that the developing country, the challenge is take care of the acute care, because that's where the whole focus is. And once the acute stage is over, the people just forget. And therefore, it is very, very important that at the point of acute care, whether it is stroke, traumatic brain injury, spinal cord injury, or any other neurological disorder, we should get neuro rehabilitation to stand with, so that people understand and don't leave when everybody is exhausted to take over the neuro rehabilitation. I'm going to speak about the disability. You all are aware, and problem is that people with disability which are more vulnerable compared to the general population, because they have a poor quality of life, poor self-perceived quality of care and support. And therefore, the rehabilitation services are really wrongly perceived as last resort after the failure of therapeutic curative intervention and are neglected. And that is where is a bigger challenge than providing the rehabilitation. And therefore, the need for rehab service become even greater in neurological disorder. And I feel that we need to infuse this to neurologists to start the neuro rehab right from the day one. And therefore, we need to strengthen the neuro rehabilitation services so that quality healthcare services can start right from the beginning. Now, you all know that 1 in 3 people would require rehabilitation at some point of time. And if you look, the need which has increased since 1990 and which has risen from 1.4 billion to 2.41 billion people. And therefore, as the number of specialists are growing, so is the disability. To look at the global disease burden of disability, and if you look at these 3 disorders, the blue is global GBD. This is a neurological disorder which we normally deal with, like Alzheimer's, PD, epilepsy, multiple sclerosis, MND, migraine, a headache, other headache. But GBD plus is beside this, we include the stroke, meningitis, encephalitis, traumatic brain injury, spinal cord injury, and then GBD plus 2, which are additional, which are not even included, like rabies, cysticercosis, neural tubal defect, neonatal trauma, birth asphyxia, and like HIV/AIDS, malaria, neck pain, back pain. So those are the other neurological disorder. And mind you, 20% contribution of rabies to neurological burden, which is itself is very good. And if you look at this disability, mortality, and incidence, lower middle income countries, they bear the brunt, and therefore global burden of disease, which is much more in these countries. And if you look at this daily, you can go through them, that these are the disorders which are much, much more common in low income and low middle income countries. And we are looking at cerebrovascular disorders. Alzheimer's is now increasing. So are the headache, Parkinson's disease, and the infection. So we need to really look into what are our priorities. Talking about India, I always feel that 1.34 billion population, and we will take over China by next year. 70% lives in rural area where agriculture is main livelihood. Cities has modern amenities, and so now there are private setup, private hospital, but it is a rural area where the problem is there, and there are 12.68 lakh allopathic and other Ayush doctor, which is forming about 1:854 ratio, and there are 32.64 nurses, so it is 1.5559 ratio, 585 medical college, and these are the MBBS and PG seats, and we are producing neurologists about 300 per year, which is increasing now. The number of physiotherapists I'm going to come, osteopath, very few neuro rehab specialists. And if you look at burden of neurological disorder across the state, these are the different states. These are the non-communicable neurological disorder, which was much more common in state where I come from, like Maharashtra. But these are communicable neurological disorder, predominantly in central part of India, UP, MP, Rajasthan, Gujarat. And these are injury related neurological disorder, which are again much more common in upper part of the India and lower part of the India. So different part of the state have different disease burden requiring different setup. And these are some of the disorders which are prevalent in India. This is the latest data of 2019, and these are male and the female. And again, they will decide what is our priority in the rehabilitation. And if you look at the daily of neurological disorder, again by age group, there's certain disorder which are much more common, like epilepsy, cerebral palsy in younger age. But as the age grows, you can see that stroke, headache, they take over. And traumatic brain injury normally start after the age of 15 years and then remain almost static. So again, these are the disorder which goes by age by population. And again, we need to plan out for them. As I was talking about the neurologists in India, these are the NSI and IN member, which is the latest data. And again, most of them are so 8% in the Chennai, 10% in Delhi, 6% in Mumbai, 5% in Calcutta. So they are segregated largely into the metros, and therefore the number of neurologists going into the smaller area is to be looked into. Again, demand and supply. So there is a huge demand, the rehab and other related is this much, but supply is only eh, absolutely low. And therefore, this needs to be really increased. And these figures illustrate that there is a huge unmet need for quality neuro rehabilitation services that exist among lower middle income country. This is human resources, at least I know in India. And these are some of the people like osteopath, nurses, do not know, neuropsychologists, now few hundred. When I started neuro rehab in 2000, they were only on the count of fingers. And now things are improving over a period of years. If you look at the need to scale up real rehabilitation, number of rehab practitioners, these are WHO data, and you can see that uh, these are in the Western Pacific region, and these look at the Eastern Southeast Asia region, very poor. Again, physiotherapists, Southeast Asia, very low. And if you look at the occupational therapists, again, Africa, Southeast Asia, very low. And same is prosthetic and orthotic. So we really need to scale up the people who are giving the rehabilitation. So these are one of the challenges in providing neuro rehab services. So we have to look into that. What are the policies and planning happening in your country? So health organization and neuro rehab services are immense task of developing correct policies, laws, delivery system with coordination strategy adapted to local needs. And these services may be confronted with expectation stemming from their institutional environment, government agency, administration, patient organization, concerning improvement of quality of care and clinical outcome. Now you look at a country like India, where largely it depends on the government setup, and the government setup has to be governed by the government. So policy need to be specifically promote the human right of people with disability. And despite that burden attributed to neurological disorder, many low middle income country in the developing world have health policy that do not cover neurological disorder at same level as the other medical condition. So we have this survey, which was the World Disability Report, 114 country, and 42% country responded that rehabilitation policies were not adopted. Percent countries legislation on rehab for people with disability was not passed. 40% countries rehabilitation program but not established. But some countries has good related policies, but less implementation of these policies, development of services, delivery of regional and local rehabilitation services. And therefore, we really need focus to bring this to the government that this must be implemented, what is their right. So this is what I have already mentioned. So we really need to have implementation, development, and delivery of regional and local rehab services. Now, infrastructure. Many persons with neurological require, high specialized skill for appropriate diagnosis and management. So you need a neurologist, you need a neurotherapy to take care of these people who have severe disability. Most developing nations lack or have limited number of adequate and efficient health services, particularly in rural area. And therefore, suppose even the stroke unit, if you ask a question across the country, all the stroke center, that how many of them have a neuro rehab services and how many of them start a neuro rehab services right on day one. I think we will not get more than 10 to 15% people responding. And I think I will take this survey and come back to you in next meeting that how many stroke unit India have and how many of them have rehab services and they start rehab services on day one. So availability of rehab services across region varies, and many developing countries still have limited or no organized rehab services. And even if there are services exist through, say, NGOs initiation, charitable organization, these are often dependent on external funding, and they are not uniform. The one good NGO may provide whatever their constitution and demand, other would provide what they feel is correct. So person with neurological disorder usually depend on the family member to help them in daily activity, and this further repeats the cycle of poverty. So resources are lack of funding. Whatever is resources available for disability, they are inadequate and inequitably distributed, and limited budget for service of neurological condition. And WHO survey shows that 10.4% of country have a separate budget for neurological illness within their health budget, and two-thirds of low economic country have no disability benefit available. So out of the pocket, because insurance doesn't cover, most of the people have to pay for their pocket, and then the priorities changes and the financial hardship stop them take a regular therapy. So the poverty is again a big factor, particularly in low and middle income country, as they have to pay from out of pocket, and it can cause both a cycle that disability leads to poverty and poverty leads to more disability. And therefore, a family has to come out and help the person and take burden. Stigma and culture belief are very, very important because the services in people with disability depend on their culture, what culture they are, and what are the stigma. Like in epilepsy, there's so much stigma attached, they don't even take the treatment. And therefore, we need to really work out with the society and the government to overcome this stigma. And this concept and social stigma lead to active exclusion of people with disability from the society. And there is evidence of wider gender inequalities in assessing rehab services in many low countries. And therefore, the female do not get the desirable treatment as compared to the male. And therefore, this again happens in the rural area. There's a lack of awareness and education, and that's where WFNR is really doing a great work, create an awareness among the rehab specialists as well as among the patients and caregiver. And we really need to push more and more on this aspect, because if you are aware about what is the treatment you can get and educating them, I think that they will demand for the right kind of the treatment. The political instability and conflict in certain countries can give rise to the lack of proper rehab services and the burden, which can also be one of the factors. The language and culture barrier, like in India, the every state has different language, and therefore the local therapist will have to overcome that. They have to learn that language to provide appropriate services to those people who are in that area. Lacune in reporting of the service need provision and outcome monitoring. There are lack of data and prevalence incidents of neurological condition. And if these are not reported appropriately to the authorities, I think this may cause long-term effect. And therefore, if they are reported, like in HIV/AIDS, chronic or in the COVID, long COVID, and when people started understanding that there is a brain fogging, there's a cognitive disability, the government could start the helpline, start the cognitive rehabilitation on the telemedicine, and it helped so many people. So that's very, very important. Now, what are the strategies to improve the neuro rehabilitation in this country? What we can do, how we should do? So the one thing is what we can do is we can involve the training non-specialist health worker, such as community worker, or those which are working in NGO and want to help, who can provide the basic neuro rehab services, or the nurses, the basic nurses. And this can help to expand the reach of neuro rehab services in area where there is a shortage of specialized health professional. And we can have task sharing, task shifting. There can be training phase where you can have the reorganization, webinars, PPE training, contemporary based evaluation, or there's a practice fair where a reduction in case to emergency urgent, establishment of clean versus contaminated team, collaboration with multidisciplinary team, and then there is a maintenance phase. And what is very interesting is tele rehabilitation. I'll come back. These these non-specialist healthcare can be guided to the rehabilitation. Now, community-based rehabilitation is something which is very, very important. And this is based on a delivery services in the community, particularly in low and middle income country. And this can facilitate early coordinated inpatient discharge, maintain continuity of rehab services among disabled neurological patients, and provide rehabilitation to neurological patients who may not require intensive hospital-based rehab. CBR is a very important program in particularly, the patient with Parkinson disease, where they can do the group therapy, can work in community, and the active community stakeholder health worker, they can guide many more people with Parkinson or stroke. So 1/3 of disabled patients can be managed by CBR, and this system of providing community-based rehabilitation is very, very important, though multidisciplinary neuro rehab services at tertiary care level would remain reserved for severely disabled patients who require the greater resources. But most of the people can go back to the community-based rehab. Now, in country like India, where community-based rehabilitation did not take off that well, the family-based rehabilitation is very important because family here is very, very close-knit. And this is again important for people who cannot travel to rehab unit, either due to the time or due to the distance or due to the finance. And those who are uncooperative patient, violent behavior of the patient or bedridden, and where there is a family burden like two people, one is working, one is disabled, how do we do? Or the old age. So these are the people where the family-based rehabilitation can be worked out. And who are the therapy giver? It could be anybody, maybe wife or daughter or the son or the father, depending on who is available in the house at the time. And they can divide, they can again split the shift and the task. And here you can see the person treating in the rural village outskirt. And this is a family of 139. This gentleman has 23 wives and 113 children. So they remain it's from Mizoram, India. These 139 people remain in one house, in one family. So that's something which is amazing about this country. So in family-based rehabilitation, family is the focal point of rehab. It helps in early diagnosis, treatment, preventing disability. Treatment approaches on family-based system. Rehabilitation is aimed at family, then the patient alone. Stress-related disability is shared. Family unit develop skill and prepared to cope with long-term effect of illness, depression and anxiety of patient and caregiver can be reduced and shared, and family members switch their role as per the need. So CBR is ideal in rural area where communities are working together under the system of the Panchayati Raj, particularly in India, where the Sarpanch, who is head of community, can be the focal point for success of CBR. On the other hand, FDR is useful in cities and metros where family is the focal point of rehab. And we really need to make a bridge between these two, at least in Indian continent and many more countries where for the successful of the rehabilitation program in the future. And this was the paper which I wrote much before the COVID. And here we insisted that smartphone uses connectivity in developing world have different model can be tried, like family member can be treated by the therapist or web-based appliance. And we started this much before in 2014 and 15, where we started patient with family-based rehabilitation, showing them the video, making them video, telling them to follow that therapy. And this became true post-COVID because then the telemedicine became a part and parcel of the therapy. So what telemedicine has done? It is an important tool that may bridge geographical discrepancy in available rehab services. Today, we are connected with the whole world, and it is useful providing continuous rehab services during pandemic, particularly among diseases like Parkinson and stroke. And it was cost effective because it's much cheaper. And IFNR has advocated for greater budget allocation and scaling up of technology in healthcare system at all level, and a sector-wide approach for strengthening tele-neuro rehab services in its positional statement, which was written during the COVID to the government. And we feel that why tele-rehab could be the solution, because in India, if you see this, there are India to lead the mobile users, India to overtake China by 24. How many doctor does India have? No one really knows, but we have the highest number of mobile services, and it is very, very cheap. If you look at this, the monthly mobile data costs you about $3. And, in $3, you can get 1 GB data, 1.5 GB data every day in your smartphone. So tele-rehabilitation, the current technology approach provides a wide range of services such as teleconsultation, tele-multimodal care, telehealth care, telehome-based care, tele-technology aid rehabilitation like robotic, telemonitoring, e-health, and cognitive rehab. And all of these modality can be considered as subfield of tele-rehabilitation and would fall under the rubric of telemedicine. So particularly for India, the strength is huge population, which is young. They're very friendly with mobile. Opportunities are technology hub, ample health startup. Many people have done tele-rehab, but weakness is limited health infrastructure, and the threats are external factor, regulatory reform, which we have to follow for this therapy. But there are still a lot of opportunities. You have neurological condition like stroke, epilepsy, headache, MS, movement disorder, which can be looked into. And you have allied services integration like PT, OT, ST, clinical psychologists, MS nurses, yoga, alternate therapy. And I've been, for last 3 years, we have been, ever since pandemic, we are providing weekly tele-rehab services, weekly speech therapies to all people with disability, with epilepsy, weekly cognitive therapy, weekly physiotherapy and occupational therapy, and this has been running very well. Trainings can be done. So we have been doing the training on tele-rehab, which can be done for the poor adaptation, maybe because of lack of knowledge, technical skill, or infrastructure availability. So Tele-Neuro Rehab Academy we need, which have structure, is certified, which would facilitate in developing infrastructure building, designing neuro-specific telemedicine platform, and national-wide enrollment and training on telemedicine for doctor and allied stakeholder. So to come to the further, the partnership between government, so that's a collaboration, non-government organization, international organization will help. And we really need to collaborate and spread. Take the expertise from these collaboration and spread it and pass on to where the people are not yet want to learn. And therefore, the WFNR or IFNR or Asian organization, they can add in expanding the workforce, spreading education, development of guidelines, training and capacity building, and advocacy at the professional level. Training and education can be at universities, international NGOs can collaborate with local counterparts, and WFNR could be again key in this developing work. Train the educator, design the curriculum, fund the courses, ensure that financial reward, incentive, and continue learning opportunities are done, improve work environment and recognition of skill, guaranteed job security and assistive technology availability in the countries can be done. So training for rehab persons should include overview of relevant national and international legislation, including the CRPD, using the assessment tool, improving communication between medical staff, tailoring for the rural community and culture difference, understanding the latest technology and research, working toward the affordable healthcare. That's very important. Evidence-based practice, working in multidisciplinary team, and exchange program with developed country. So these will help. Invest in the education and training. That is what is important. And address the socioeconomic factor, because that is what is very important, because socioeconomic factors, poverty, lack of transportation, inadequate healthcare infrastructure, they will impact access to neuro rehab services, and they need to be really looked into. And therefore, implementation of public health campaign to raise awareness about neurological condition and their treatment options, providing transportation services to patients with invest in healthcare infrastructure are important. And NGO could be very important in this. Culturally sensitive approach is very important. And finally, data collection and research is what is important, because once they have the data and research, they would be able to modify and plan out. And this is what they need to do. They have to have leaders and partners and formulate their own system to have the data collection and the research. So what are the recommendations? You have to have national rural rehab program, expanding research into affordable rehabilitation, techniques and evidence-based practice, international collaboration with developed country, introducing courses and progress in neuro rehab from National Institute to the local hospital. So if we follow them in years to come, we will develop a system where the proper, appropriate rehab services will be provided. So Rehab 2030, a call to action is what WHO undertook to the stakeholder meeting in 2017. And this meeting emphasized the need for integrating rehab services at all levels in order to achieve universal health cover. And India came out with the National Health Policy 2017 for the disability, where they included 23 disorders, and among them from 8 to 14 neurological disorders were covered under the disability, and therefore they are covered under the policy of the government and to provide, rehabilitation, geriatric and palliative care services. Health card linking is what they are looking at. They will give health card link family to a primary health care facility unusable throughout the country, which has been proposed and which would ensure greater uptake of service among the poorest of poor. And linkage of this wellness center with district and tertiary level of healthcare through the digital health would ensure a continuum of care at primary level where neuro rehab services would otherwise reach seldomly. So to conclude, strengthening neuro rehab services in India and other LMIC at primary as well as district level for better functional outcome and quality of life among patients living with neurological disorder in this country. To have the greatest effect on population health, careful attention need to be given to the system that deliver these services. The training and skill of neuro rehab workforce and monitoring of neuro rehabilitation delivery to client is key. Even though rehabilitation plays a critical role in optimizing health outcome, advances in this field have been found lagging. Recognizing the neurorehabilitation contribution to improve the functioning and the quality of life among patients with neurological illness is fundamental and in correcting this disparity. To summarize, neurorehabilitation in India has gone a long way. in last decade from infancy, and recognition by neurologists and government is happening. Therefore, we need to have a concrete plan of action to them so that they continue to take interest. Setup of low cost center, particularly in rural areas, is key, and we have been promoting them. COVID-19 has caused hard time for people with disability, but we have learned a lot and adapted to situation. Teaching and training online has become a very big plus point, and I must say that IAPNR has taken a lead in 2020 April, where we organized 30 webinars for people. More than 5,000 have attended each webinar, and we really got a wonderful response on this training, which was a helpless situation, but boon for many students and young therapists across globe who develop a lot of interest in neuro rehab. Which emphasizes the need of structural training in neuro rehab around the world and in Asia. Long-term therapy may be slowly replaced by tele-rehabilitation and family-based rehabilitation. We need to adapt, and neuro rehabilitation services in low-middle income country will be entirely different in years to come. Join hand with organizations like WFNR, IFNR, WHO for improving care and bringing a uniform rehab services in your country. IFNR Con 2023 would be from 14th to 16th of April, and you are all welcome because this is a hybrid meeting. Thank you very much for your patient hearing. Thank you.
Okay, Nirmal, thank you very, very much indeed. That was a very comprehensive and it was a very wise speech on many, many aspects of bringing forward neurorehabilitation services in a country like India, for instance, and any other as well. And I think that you made some very important points. And what is certainly clear that over the years, we have learned a lot how we eventually have to change the classical paradigm into a more modern and paradigm, also using telecommunication, also using digital communication technologies, much more. And I totally agree that a facilitator in this sense was the COVID-19 pandemic, of course, because it has certainly increased our ease in dealing with this and using this. And I think we certainly should develop on this much, much further. WFNR at the moment is rolling out 2 activities. One is especially devoted to educational advances in the field of community and family-based rehabilitation. So it's devoted more to the patient and the families and caregivers rather than to professionals. And the other is that we are just starting to do a new survey on the actual state of affairs, also taking into account the aspects you mentioned. That is also the availability of digital communication tools, but they are widely used. And they, as you mentioned, they are really cheap. And basically, I think this paradigmatic change in going away from well, you have acute care in a hospital, you have rehab care in a hospital, you have maybe outpatient care later on and home. That is probably not sufficient anymore. And we have to go to, let's say, more elaborate ways of dealing with it, especially in rolling it out in these rural areas. You mentioned 70% of people in India living in rural areas. That is very similar in many other areas of the world, including China. And that is probably the future. And it's on us, really, to design the future, how it may look like. You also mentioned the tremendous impact that hostile activities, wars, or conflicts have. And our position in this respect is very clear. We are not going to be affected with any conflict and take part of one or the other conflict partners, but we like to stress and to emphasize again all sort of these hostile activities against the human mind, and we can do much better, and that's just negotiating and finding elegant ways. For whatever reason, people like to kill each other, and that is a bad thing, that's for sure. But hopefully in future it will change a little bit.
Right.
Okay, so thanks again. Let me look at the, there are any questions? Well, is there any participation certificate of this webinar? Basically not, but if you want one, we can send you one. That's not a problem. Okay, so not much more from the question and answer section at the moment. So I open it to our panel. Stephanie.
Congratulations on the wonderful talk. Thank you.
Thank you. Thank you.
In 1218, the World Congress was in India, and it was impressive, the participation of patient organizations and of political figures who came and celebrities. This was really not only specialist among ourselves, but really the wide range of public. Could you please comment on that? How that happened, that people were so much involved, and how it's going since then?
So I always feel that unless we involve the stakeholders, we will never be successful in providing delivery, because what may feel is this right for this patient, but patient or the stakeholder may have other feeling. So what they really want, what are their priority? If the rehab specialists do not understand, then it is futile that we will be able to provide them, and we will able to have them in confidence. To build up that, I took control of all the organization. So we have the NGOs like Multiple Sclerosis Society of India, the Stroke, the Cerebral Palsy, the Traumatic Brain Injury, Indian Head Injury Society, Indian Spinal Cord Injury Society. So I requested those organizations to come together. And this we started, and this is being continued. I must tell you that in November at the Indian Academy of Neurology and Asian Oceanians Congress of Neurology, which was held at New Delhi, I had more than 500 patients participated. And we had 10 organizations doing their meeting. And in some of them, there were more than 100 patients and caregivers participated, including in the motor neuron disease, where one of the patient's sister, he came out with certain new modification in the ventilator because her brother had MND. So these are the people who have really thought about what can really help. And we got one of the organization, India has Niti Aayog, who fund and who make the policies. We got the CEO of Niti Aayog come and address in a common session where all these 500 people were there. And they insisted on what are their requirements, how they can be helped. So this will help. Now we will again this next conference, which is in Mumbai. I have kept a session for 3 hours where all the NGO have called, and there the stakeholders along with the people who are looking after them to present themselves and come out with a common minimum program on disability. Because I feel that rather than separating it to stroke, multiple sclerosis, head injury, we have a common neurological disorder. If all of them come together and give the 10 problems which are common, I think they will make much more impact to the government, because government will like to hear all coming together rather than individual coming. And I'm really trying my hard to get all of them together and at least succeed in sending their message to the people who it matters. And I think this also give them confidence that there are some doctors who are ready to listen to their problem rather than dictating that you do this and you do that.
Yeah, that's perfectly clear. Yeah. Mayova, any comment from your side?
Yes, I think I agree that if we are going to engage policy makers, they usually like to kill, if possible, 20 birds with one stone, because they have limited resources. So they usually would want us to be as synergistic as possible, because if they get approached by several groups for the same pot of soup. You know, they have difficulties in knowing how to share in an equitable way to have the greatest impact. So they really want to achieve as much as possible with whatever they have. So, and that is why it's important for neurorehabilitation, you know, drive to leverage ongoing activities, like we mentioned, the WHO IGAP, the Brain Health Initiative, which has already sensitized governments, you know, across the globe. Leveraging that, we can then push the agenda of rehabilitation, neurorehabilitation, that is as cross-cutting as possible. And to give an example, which I mentioned, in Africa, I'm working directly with the WHO Africa region to domesticate the WHO Intersectoral Global Action Plan against epilepsy and other neurological conditions in Africa. And we're doing a situational analysis. There are about 5 different terms of reference, of course, which includes looking at the burden, the determinants. The second term of reference is looking at the legislative landscape and gaps, including stigmas and all of that, discrimination, human rights. The third one is health system response. And the fourth one is the challenges, you know, and of course, the fifth one is recommendations. And we try to make this as cross-cutting as possible. We looked at the 5 conditions that had the largest burden: stroke, dementia, epilepsy, headache, Parkinson's disease, you know, and they are doing something already on meningitis. So we are bringing all of this together. And like I mentioned, we are likely to have a launching of this that is going to involve the ministers of health across the 47 African countries. So it's going to be a powerful statement that will really help to drive the agenda of neurorehabilitation. So to come back to the main point is that in engaging policymakers, we have to speak their language. We have to put on their cap and see the way they look at things and see how we can kill 20 birds with one stone. Thank you very much.
That's a good point, Mayowa. And sometimes it may be difficult to talk to the politicians, and you're right that is sometimes a discourse problem if we don't speak the right languages. Apurva is with us, and he raised his hand. So, Apurva, please.
Hi. So I congratulate Nirmal and all other speakers for today's wonderful webinar. I agree with Nirmal that the strength lies in number. And if we have joint voice of persons suffering from different neurological disabilities on one platform, and our voice will reach in a more effective manner to all the stakeholders, particularly the policymakers. But at the same time, there is a value for individual disease-specific associations also, because the needs of different types of disabilities can be slightly different. Of course, there is a lot of overlap. At the same time, there are differences in the needs of different type of neurological disease. So the role for both will be there. So disease-specific patient support groups and a network or a composition, combined voice of all the neuro disabilities. Both are necessary. They are synergistic to each other. Thank you.
A very important point, what you mentioned. And it may at times be very difficult to do that.
Yes.
Sometimes bringing different stakeholder parties in together can be very difficult, but nevertheless, there's no other way of doing it. That's certainly right. Stephanie, any further comment? No. Normal?
Thank you very much for listening to me.
Mayowa? Obviously not at the moment. Okay, let me look briefly. There's nothing new in the question and answer forum. Let me thank the speakers again. I think it was a very good and extremely informative meeting, and also a meeting bringing things forward in terms of marshalling our thinking, how to design the future in this field. Thanks also to Christian, who is always responsible in the back office to organize all this technically. It was, as usual, perfect. Christian, thank you very much for that. So all of you stay with us. We will have the next session tomorrow at the same time. on day 5. And we'll have the pleasure to have Stephanie Clark and Apurva Puranik, you've seen already, today speaking on rehabilitation in cognitive and language disorders. So thank you very much, all of you, for participating. Take care. See you tomorrow. Thanks a lot.
Bye.
Good night, everybody.
Good night.
Yeah, thank you very much.
Thanks.
Thank you, Maiva.
Welcome.
Bye-bye.
Thank
So you have to learn how to him and kill 20 birds with one stone.
That's a good. I like this. Yeah. Okay, thanks a lot. Have a good time.